Good evening, everyone. I'm Gavin Yamey, and on behalf of the World Affairs Council and Accordia Global Health Foundation, I will be your moderator this evening. It's my very great pleasure to introduce tonight's three very distinguished speakers. Alex Coutinho chairs the board of the International AIDS Vaccine Initiative and was formerly the executive director of Uganda's Infectious Diseases Institute. He works with the Accordia Global Health Foundation to increase Ebola preparedness and to advocate for structural, systemic changes to prevent future outbreaks. Jane Coyne is the Director of Operations at We Care Solar, and she's a member of the Board of Directors of Médecins Sans Frontières USA. She's worked for MSF for over a decade now, and has managed on-the-ground relief efforts in Uganda, Sri Lanka, Nigeria, the Central African Republic, the Democratic Republic of Congo, and Sudan. And Ian Crozier is a US-trained infectious disease specialist who's been working in Uganda for the past 5 years, including training, mentoring, supervising Ugandan physicians in HIV and AIDS care. In August of this year, he was deployed by the World Health Organization to an Ebola treatment unit in Sierra Leone, where he treated patients with Ebola and where he also contracted Ebola himself. He was treated here in the US at Emory University Hospital, and if you haven't yet seen the extraordinary feature about his illness and recovery, in yesterday's New York Times, an Ebola doctor's return from the edge of death, I urge you to do so. Ladies and gentlemen, please then join me in welcoming Alex Coutinho, Jane Coyne, and Ian Crozier for a conversation about the Ebola outbreak and what it can tell us about health systems and our ability to respond to epidemics. So let's begin by setting the scene. The current Ebola outbreak in West Africa is by far the largest in history since the disease was first identified back in 1976. It is unprecedented in its magnitude, its spread, its deadliness, and I would argue in the challenges that global health agencies have faced in tackling it. Since the first case in December 2013, identified in a 2-year-old in Guinea, the WHO now reports that there have been over 17,000 cases and more than 6,000 reported deaths. So tonight I hope we can explore some of the really crucial questions about this Ebola outbreak. Why, for example, did it spin out of control so quickly, so aggressively, particularly in Guinea, Liberia, Sierra Leone? If we've had Ebola for 40 years, why on earth do we not have a drug treatment or a vaccine? And critically, how can national governments and we, the international community, through international collective action, how can we be better prepared for future infectious disease outbreaks? Jane, could you begin by giving us a snapshot of the situation on the ground today in West Africa? How did this outbreak evolve, and do you see signs that we are at last getting on top of it?
Thanks so much. First, MSF equals Médecins Sans Frontières equals Doctors Without Borders. So just to be clear, I'll use the term MSF because it's significantly shorter than DWB. You used the word unprecedented. That was the term that was highlighted in the tagline of the first article that MSF wrote about this epidemic in March, unprecedented. In June, we said it was out of control. And it wasn't until September that we saw any significant commitments for international response. So the actors on the ground were massively struggling to keep up with the caseload and burden. And here we are today, now 3 months since the commitments have been made. So I'll give you a summary kind of by country because the situation in each country is slightly different. So Sierra Leone, I think, is probably in the worst shape right now. So It has the dubious distinction of today being the country with the highest caseload, so the cumulative case burden. They surpassed Liberia just today. That's because there's been a dramatic rise in the number of cases in the recent weeks in Sierra Leone in general, but more importantly, concentrated in the western region, so really around the capital and Port Loko. So the capital is Freetown and Port Loko. Unfortunately, this coincides with the slowest international response. So in September, the UK government committed to building 700 treatment beds in the country. And as of November 27th, there were 11 beds functioning. There's apparently a few beds more that are functioning today. I think Save the Children's new facility has some treatment beds available, but the bulk of that capacity is going to come online, if ever, after the new year. And that's clearly going to be too late for Freetown. So people are really expecting that the magnitude of problem that we saw in Monrovia in August and September is going to be hitting Freetown in the coming weeks. And that is devastating, most importantly for the Sierra Leonean population, but for the health workers and everyone that's trying to work there. It's elucidated by a story. Last weekend, there were 9 patients that traveled from Freetown to Kailahun to get access to treatment because there was no capacity in Freetown. That's like going from San Francisco to Portland, Maine to get access to treatment. It is all the way across the country. Never mind the potential infection risk along the way. It's ridiculous that patients would have to travel that far. Liberia, it's clear that the aid is arriving in Liberia, but we're really struggling with a very basic fact about this epidemic. We're not able to predict future demand, and it takes a long time to make capacity available. So in August and September, the vast majority of cases for the whole epidemic were concentrated in Monrovia. And today, there's 3 times as much capacity as there was in August and September, but there's a quarter of the cases. So we probably have 5 times as many treatment beds available in Monrovia as they need right now. And the caseload in Monrovia is very, very low, but the caseload in the rest of the country is stable or increasing. And so I think the ability to adapt is going to be one of the major challenges in responding to this epidemic as we move forward. There's other problems in Liberia like lab issues. So we now have new airlift capacity, which gets people and things from the capital to these remote locations. Liberia is extremely challenging logistically, but the helicopters won't carry blood samples or patients, so it doesn't really help some of the basic problems. Guinea is the smallest country of the 3 and has the lowest case burden right now, but I think has really been overlooked. So the development of capacity in Guinea has been very, very slow. There are very, very few international actors. And Guinea is struggling as well. So today, I just read 17 out of 33 districts in Guinea have reported cases in the last 3 weeks, which is to say that they have an active epidemic ongoing. There's only 4 treatment centers, and the overall caseload is up 25% this month compared to last. So none of that portrays a very promising picture. I think what we can say in general is that there's very real challenges with the disease. We don't understand the disease and the transmission all that well. We have very poor epidemiology, so understanding the basic facts about the epidemic. How many cases? How many people are dying? How soon are they getting access to treatment? Are they in treatment? Those questions we don't have very good answers to because the data collection, while it is improving, is imperfect. So we have poor data. We have a poor understanding of the disease in terms of our capacity to do analytics. We don't really have a great chance of getting the capacity in the places that we need it. So I think that Freetown, it doesn't matter what I think. The people that are closer to this than I am believe that Freetown is particularly going to be bad in the coming weeks. And they're making plans for 2015 and 2016. This epidemic is not going away soon. So I think I'll leave it at that. Kind of bleak, sorry.
Alex, we've heard this bleak situational analysis from Jane. You know, in previous Ebola outbreaks, they have tended to be relatively small, handful of cases or more, relatively quickly contained. This one has been very different. Why has it been so different? And what role do you think that weaknesses or fragile health systems played a part?
So I'll look at this at three important points. First is, I am from Uganda, and I've been working as a doctor all my life in Africa, mainly in Uganda. Uganda has the distinction of having had the most Ebola epidemics, 5 epidemics in the last 14 years, but of a very small scale. Mainly a small scale because Uganda was able to contain these epidemics before they exploded into the kind of scenarios that we are seeing. Of course, all of these 5 epidemics, apart from one in Gulu, were in mainly rural areas. They were not in built-up urban areas. So there are 3 points. First is, why did Ebola appear in West Africa? Never had. All the previous epidemics were in East Africa and in Central Africa. There had been 2 cases appearing in West Africa, but that was not really considered as an epidemic. So why West Africa? The speculation is that the Ebola virus is found and coexists in fruit bats. Not every single fruit bat, but perhaps 1% of all fruit bats. And the habitat for fruit bats does extend into Guinea and Liberia and Sierra Leone. And so an epidemic appeared in a part of the world that was not expecting it at all. And so it took quite a while for people to even recognize that what was being seen was Ebola, because this is an area that had had another disease that's similar called Lassa fever, but they'd never seen Ebola. So it took some time. And whilst people were still figuring it's something else, that disease was already spreading within the community. Added to that, that these 3 countries have gone through, at least 2 of them have gone through civil war, and all 3 have gone through some form of political turmoil. And there was great suspicion, and continues to be great suspicion, between the population and the government in power. In order to control Ebola, the community and the population needs to work very closely with the government to work together to cooperate, because they're going to be asked to do things that they would not normally do. They're going to be asked to bring their relatives into a treatment center and leave them there. And if they die, they won't be allowed to bury their beloved ones. Now, even here in the United States, that would be a tall order. But if people understood, they would follow those guidelines. But in a situation where the population does not trust the government, this also delayed people being willing to bring their patients forward. So the second point to analyze is, why, though, is this epidemic so unprecedented? 17,000. Previous epidemics were 300, 400. Well, I believe, I don't have all the answers, I believe it's because the previous epidemics never really went beyond 300 that everybody kept saying, okay, we have Ebola, but previous experience tells us that it's going to die out, it's going to extinguish if we do this and that. So there was a little bit of complacency in those agencies that should have responded quickly, believing that if it is Ebola, this will follow the typical course. But this time, Ebola evolved in a community that was not similar to East Africa or Central Africa. In addition, the Ebola virus was then able to migrate into rural areas, into big cities that, although we call them cities, are predominantly slums, predominantly populations that are packed together like sardines, so to speak, with very little in the form of infrastructure. And you often find that in a little room, you have 6 or 7 or 8 people staying there. So the virus found it very easy to essentially, excuse the pun, go viral. So we then had a situation where, and you reach a critical point where the more cases you have, the much easier it is to infect other people. Now, there are 3 or 4 areas where this virus has typically adapted to its multiplication. First is within the family, because in Africa, as here in San Francisco, the first caregivers are the family. So if someone has Ebola, their family, the children, the adults will help to care for this individual. And with the infectiousness of Ebola, that family will easily be infected. Now, Ordinarily, as soon as you recognize that you have Ebola, you encourage every single person with symptoms to be brought into a hospital to be quarantined and treated. This epidemic got so out of hand that for the first time, and I could not believe this, policy was there aren't enough beds, so try to treat the patients at home. Home-based care for Ebola is crazy, frankly. But it got to that point because I guess there were no other alternatives. And families also were very reluctant to bring their loved ones to treatment units, partly because they disappeared in the treatment unit and there was not enough communication about whether even they were alive or dead. And if they died, they were buried within a couple of hours. And for many people in Africa, death is not the end. Death is a continuation of life in a way. You take on a spiritual form, but there have to be certain burial rites that ease that passage from fully alive to the spirit world. And Ebola is telling you, you are not going to do that. And many, many people in this part of the world believe your spirit will wander around restlessly and disturbing you if you don't do the burial rites. And so many people go ahead and do the burial rites, even though they know it's risky. The second amplification point is burial procedures. And in fact, many of the amplifications took place when dead people were being prepared for burial. And, you know, sometimes when we hear this in Africa, when I have spoken to expatriates, they say, why do you touch the dead body? But even in America, people touch dead bodies. So it's not as if when someone dies, you completely cut yourself away. But touching a dead body is very dangerous in the case of Ebola. Then finally, the health facilities themselves also became amplification centers. So particularly in the first cases, when these cases came into hospitals, before people knew they were Ebola, many health workers got infected. And so the virus got passage within the health workers. But tragically, later on, because there were delays in diagnosis, because the laboratories that could diagnose Ebola were far away from many of the centers, many suspected cases for Ebola had to be kept in a holding center. And up to 50% didn't have Ebola. They might have had malaria or some other cause of fever. But they were in these holding centers with a whole set of people who actually had Ebola. And it's suspected that some people might have actually picked up Ebola while waiting for their diagnosis to be proven. So unfortunately, these were all things that have caused amplification. But the underlying causes are really that this was a population that did not really, had no previous experience about Ebola, was very suspicious of the government. There was very poor epidemiological surveillance, so there weren't systems to pick up abnormal diseases or abnormal deaths. And then, of course, the entire health system in these three countries is very weak, even weaker than Uganda, because of having gone through a civil war. And in order to respond to an epidemic, you do need good health systems. Finally, the third point is the United States is committing $6 billion. The United Nations had set a target of $1 billion to help these countries. If you go to Sierra Leone today or Liberia, you have 100 different agencies on the ground. The question is, despite all of that, why are we not able to get on top of the epidemic? I'll stop there, but hopefully we'll come back to that point to try to understand why with $6 billion, the US military, the British military, 100 different organizations, WHO, MSF, why are we still at a point where we are talking of the whole of 2015 and 2016? And what could we do to try and end this epidemic by June 2015?
Alex, Jane, thank you for illuminating the situation on the ground and some of the challenges that the community faces in tackling this outbreak. Ian, I wanted to turn to you, and first of all, I think that everyone in this room and everyone listening to this broadcast must, I think, share the same sentiment, which is immense gratitude to you and your colleagues, West African nationals, international volunteers, for your clinical service, despite the risks involved. So thank you for that. When you contracted the disease and you were treated at Emory Hospital, initially your identity was under wraps. But as of this weekend, starting with the New York Times piece, you went public to share your story. Why did you decide to do that?
24 hours later, perhaps I'm not really sure this evening. First of all, it's a pleasure to be with you, You're among the first people I've had long conversations with about much of this, and it's a real pleasure to be anywhere, to be honest. So thank you. I could talk about sort of two different stories that are overlapping for sure. Number one, I was a doctor in Kenema in August, and this was prior to the scaling up that Jane just talked about. Kenema was one of two ETUs in the country, right smack dab in the corridor as it came from Gekadu, and the outbreak came down. And went there in August, and I could talk about that for a long time. I'd love to, actually. So I'm going to summarize a couple of things really quickly. And then talk about a second story, which is I was a patient at Emory in September. And that combination of experiences as a clinician and a patient is quite remarkable. And I'm still processing much of it. I've been an artful dodger at staying off the grid, right? None of you have even heard of me, I think. And I'm a pretty small fry to be on a panel with distinguished guests like this. But the main reason that we wanted to kind of break silence, number one, I received unparalleled care from a group of doctors and nurses at the Emory Isolation Unit. I think unlike anywhere else in the world, but of course there are lots of other places that could provide that care. This occurred in a setting in which there are many naysayers about whether we should be providing this level of critical care to Ebola patients. In fact, in general, it's my experience even that people who develop kidney failure and other multi-system organ failure, which I did, they die. Yeah? And I think it's a different discussion about being evacuated or not. We can have that discussion, but I would have been dead a week later in Kenema, and I'm very grateful, first of all, and want to acknowledge that specific team of doctors and nurses that took care of me. I have the dubious distinction of being the sickest Ebola survivor ever, we think, yeah? So I don't know this. My first 3 weeks of my hospitalization in Emory, I was completely out of it. I remember nothing of it. But when I woke, I sort of borrowed what I'm telling you now from my family. That's my brother sitting there who's taking great care of me in the past few months. And from my doctors, and interestingly from my chart, which is a really interesting position to be in, reading your own chart. But I was very, very sick. So I'm not going to summarize all of that. We don't have time. But I'd be interested to talk about it with you because I'm still thinking through it. But you know, very few people have been given that level of critical care, including intubation for 12 days. So I was on a mechanical ventilator. My kidneys failed, and I required a dialysis machine to do what my kidneys do for 3 weeks, among many other things. So the second thing is that there's a great deal to learn for the medical and scientific community from my specific case. Some of that's already coming out. A paper a few weeks ago that first described how to technically dialyze someone in an Ebola unit. You know, does the fluid that comes away from the dialysis machine contain Ebola? Is it safe? And much more of that's going to be happening. I've got some problems with my eyes that we don't understand, and it's going to be really important and a privilege to be able to contribute to that body of literature. So that's the second thing. But the third thing, and I think this is the reason we're here, you know, I am one patient who had 20 incredible clinicians taking care of me at Emory, and the ratio is quite different on the other side. In Kenema, we were a few clinicians taking care for sometimes for 80 or 90 patients. And my individual story here is very connected to individual stories, some who can tell their stories, and at least 6,000 who can't. And so part of the motivation for this was to really redirect. Our attention span is so short, and this is not a transient process. The window, we're quite confident, I think, in the past 2 weeks about our progress, and this window is not a permanently open window. And so I think just a redirection to I was there for a month. International people, we get lots of kudos for going for 3 or 4 weeks, but those Sierra Leonean staff on a daily basis, probably now soon, in an hour or so, will be sort of quietly and resolutely getting up as they do every day and walk into an incredibly grim environment and just do what they need to do. And they're incredibly sort of heroic people there. So I think to redirect the focus is the third reason. It's a rambly answer.
Thank you for sharing that very powerful story. You know, I've been really quite shocked at some of the negative attitudes towards healthcare providers who have volunteered their time and returned to the United States. There seems to be a great deal of stigma, of fear, of panic. Margaret Chan, the Director General of the WHO, has argued that fear and panic are spreading faster than the virus. And I wonder if you might comment as someone who's been on both sides, both as a physician and a patient, about the role of kind of fear and mistruths and stigma in this outbreak.
Perhaps I could comment in two specific arenas. Let's stay at home here first. So when I woke up, this was a day or two after my 27th, or not my 27th birthday. I wish.
What do you like?
My 44th birthday on the 27th.
You look 27.
Yeah, thank you, Gavin. You haven't seen my hair falling out here, but it was quite shocking because that was around the time that Mr. Duncan had died, you know. And Mr. Duncan and Dr. Celia are very similar to my clinical presentation. And it was shocking to me, the shallow and dramatic coverage, to be honest. I think sometimes we should be ashamed of ourselves that we allowed these kinds of conversations to occur and to overshadow what really needs to be talked about. So I think there certainly is a lot of miseducation, simple miseducation. We are not about to have a national epidemic here. Of course, there are things we need to be very, very careful about as we screen and think through it, but we are not the average man here in danger of getting Ebola down the street. And so I've even noticed that as I've talked to people close to me. I think perhaps this also occurs, the stigma and the myth and the fear in trying to, so a treatment unit has two functions essentially, right? The public health function is to segregate and separate infected patients. Why? To get them out of the community and prevent transmission. And the second function, which I think has lagged behind, is to actually provide care in a meaningful way to those patients. And there is a great deal of misinformation, of myth and fear surrounding that on the ground in these countries. I particularly noticed it in Sierra Leone, where it's quite difficult to get people to come and leave their family members at a place. All they hear about is they don't leave. Nobody leaves this place. We don't see them. And this is just to sort of hide us from the rest of the community. So there's a lot of that on the ground as well. I think it'll be a continuing issue as long as this epidemic continues.
Jane, there's a question that I have for you that actually several audience members also wanted some information on, and that is, why was Ian, when he was working in a treatment center, why was he empty-handed? Why was his clinical cupboard bare? The disease has been around for 40 years. Why no medicine or vaccine? And we're starting to hear about trials right now. Are they promising? How does the pipeline look? Where do you think this avenue of science might be heading?
I wish I had a more satisfying answer to that question. I think that largely the answer to the question, why don't we have a treatment or a vaccine today, is because the entire drug development pipeline is oriented around profit. Like the decision-making and selection process for what a company would choose to work on is based on the potential for sales and revenue. And there are institutions, and it certainly should be a government function, in my opinion, to direct research dollars towards the more neglected diseases. And MSF, amongst many organizations, has been advocating for years for neglected diseases, either diseases that have low economic potential because of the volume of patients that might be served or because of the economic situation of the patients in particular. And to be honest, maybe the most fundamental problem is lack of foresight. So you alluded to the fact that we've been having these epidemics for 40 years. No one really thought this was going to happen. So it hasn't even been on the radar screen of MSF. So I think that there's a combination of lack of foresight and the fact that market forces don't lead anyone to work on a solution for Ebola. So where we are today is, I think, slightly better off than where we were 3 months ago. But that just means that the compression of the pipeline to develop these new drugs and vaccines is being shortened, I think, probably as much as possible. But realistically, it takes 5 to 10 years to bring a drug to market. This is not a short cycle. And they're trying to do that 5 to 10 year cycle in 6 months. So on the vaccine side, there are 2 vaccines that have are just in the process of passing their phase 1 safety and minimal efficacy. So they're testing to make sure people don't get sick when they're injected with a vaccine, and they're testing immunogenicity, which is to say that there's an immune response to the vaccine that's being injected into the body. The process here out is phase 2 trials, which are starting probably in January and February. And if those trials are positive, then you could potentially see the scale up of manufacturing in the first half of 2015, and the potential for vaccines to be available at the end of 2015, maybe 2016, with some volume. But that volume is not going to treat all of the people in the world. And there's lots of potential obstacles on the way. So it is far from certain that that path will be complete. There's questions about dosage. Will it be too high a volume? There's questions of how long the immune protection will last. Is it going to last for 12 months, 24 months, longer than that? And we don't have time to test any of that. So the vaccine pipeline is probably a little bit farther out, but that's clearly the thing that's going to help stop the epidemic. And from the treatment side, there are drugs that have been used for other treatments and drugs that are in the pipeline that are currently being tested. And we don't really think of it as a drug, but there's also testing starting on convalescent plasma, which is to say the blood from people that have survived and have antibodies towards the Ebola virus being transfused into patients. So currently there are 3 trials for therapeutic treatments that are starting in MSF facilities in the month of December, potentially into January. But those trials are going to be, are using, I think, probably the most flexible and adaptive approach to try to get early results and to try to create a therapeutic protocol. At the same time, they're just testing the basic efficacy of the drug. So I think the overall efforts are reasonably well coordinated. They're doing the best they can to compress the cycles, but the reality is that the pipeline is quite long.
Ian, you wanted to follow up on that?
Yeah, I'd like to comment. I'm pretty invested emotionally in some of these new treatments, yeah? So a British nurse that I diagnosed while I was in Kenema was evac'd by the RAF to the Royal Free facility in London and came out. While I was at my sickest, Will, who was a friend and a colleague of mine, emergently flew over to give me 3 liters of plasma. I can't say anything about whether that plasma, those antibodies that he's now developed, and now that I have, I'll donate some in Emory in 2 days, actually are effective without really studying them, right? And the difficult question now as we go forward also is how do we best study them? You know, what's the standard? What's the standard of control? But I want to, I think we're often focused on new treatments, whether it's a direct antiviral like cidofovir or serum or vaccines, without remembering that the barriers to reducing mortality in these countries, not all the way, but reducing them significantly, are not material resources and perhaps not even intellectual right now. They exist already. They're IV bags, I believe, IV bags, IV catheters, and aggressive use of what we call crystalloid replacement, giving fluids back, because the primary driver of a lot of the disease is severe dehydration that comes from, I had 8 liters of diarrhea a day. If you can't replace that, you'll go down a road that you should be able to prevent, right? So those are very, very simple. They've been around for years. What's the problem? One of the problems is that to really be able to deliver that care, you have to be present at the bedside. And so skilled personnel who are available to be able to really manage this critical illness. Some of the things we do are simple. They're just giving IV hydration, or even better, if someone's drinking, giving aggressive use of oral rehydration solution before that. But those things require active care on the unit, and that's very, very difficult in PPE. It's just a reality of taking care of this virus.
PPE is personal protective equipment.
Personal protective equipment, yes.
I just wanted to say I feel sort of 6 degrees of separation to Ian, because my sister is a physical therapist at the Royal Free Hospital in London. She treated William Pooley, a patient who recovered from Ebola and then gave his plasma to Ian. So I feel we're somehow connected.
I'll give you some advice.
Can I give a little slightly different spin on some things that were said? First is that whilst the fear and the panic and even the stigma in communities around the world is something that is alarming, if you look at it from a different angle, it was extremely beneficial. It was beneficial that Ebola patients, including Ian, came to the United States. It was beneficial that patients went to Europe, because it stopped being an Africa-only problem. It really became a global problem, and that led to the ability to marshal global resources to address this problem, including speeding up the process of seeking new treatments. So every coin has two sides, and despite all of the stuff that was going around that, there is this benefit. It's like I've always said, thank God HIV did not just appear in Africa, but that it also appeared in other parts of the world, because otherwise HIV would now be just a neglected tropical disease without perhaps the treatments that we have. So that's the first. The second is with regard to development of drugs and vaccines. It's true that there are things that we could have moved faster, but the way we test new treatments and new vaccines require a critical mass of people to have a disease.
Yeah.
And so we need to be fair that in previous epidemics that were really small, it was just not scientifically possible to have tested, new vaccines or new treatments. We could have brought them up to the point at which they could be tested if a big epidemic came, but no one ever knew a big epidemic would come. Paradoxically, right now, while this epidemic is still raging, we have a window of 6 to 12 months to really get our act together and test these treatments and vaccines. If we are not able to do that, we are going to have to wait for another big epidemic, which we don't really want. So it's important that we see these different aspects of some of the things, because it's very easy to say that it's because it's a disease of poverty, which is true. And I'll give an example of that. This intervention to use convalescent serum was not discovered in America. It was actually used in Congo by Congolese doctors around 1985. And the expatriates who were in Congo were aghast that blood could be used because the screening processes were not very good. But clearly that knowledge could have been improved on in the years that ensued. It's only now, how many years later, nearly 30 years later, that we are revisiting this to do randomized, and that's not excusable. We should have done that testing much, much earlier. So it is a complex disease. It is complex the way we have to respond to it. But now we have a challenge, but we also have a golden opportunity to really get the final answers to tackle this disease once and for all. Otherwise, we will get another big epidemic, and we still won't have the tools to deal with it.
We've had lots of questions from this very intellectually curious and engaged audience, and I would really like to bring as many of those questions into this conversation as I can in the remaining time. Several people in the audience have highlighted the fact that Nigeria seemed to do remarkably well in getting on top of its outbreak, and a couple of people have wondered, were they piggybacking on their polio surveillance system? Was it the fact that they had polio awareness, capacity to respond in place, that they could simply adapt? What was going on in Nigeria?
So
Alex?
let's come back from Nigeria. Accordia Global Health Foundation is working with the West African Infectious Diseases Institute to help Nigeria learn lessons from their small epidemic, really small, 20 patients, 8 dead. Of course, 1 dead is too many, but small epidemic. but also to help Nigeria to get ready for the next one, because it could get the next one tomorrow. And I met with most of the players who dealt with that epidemic, and everyone agrees Nigeria was very, very lucky, very lucky. Patient flew in business class, collapsed on the plane, was immediately identified before he could leave the airport, was taken to a private hospital in a private room where a doctor recognized that this could be Ebola. And so within a few hours, they had started responding to patient 0 in Nigeria. And even then, 20 people still got infected, including the doctor who identified it, and tragically she died. So Nigeria was very lucky. The trouble is that Nigeria now could believe that it knows how to tackle Ebola. And our job in Accordia and YD is to help Nigeria understand that they were lucky, but there are things that we can do to prevent the next one, or if it does occur, to prevent it deteriorating. Nigeria has a population of 200 million people, many of whom live in very similar conditions to Liberia and Sierra Leone. It would be a disaster.
Yeah. Ian, there's an audience member who asks, can infected but recovered patients be caregivers? Do they need any protection? And if professionals who are infected are willing to return, what is recommended? I hear from the New York Times you're heading back. Is that right?
Yeah, I would love to head back. I've got a little more to work on and get stronger. But it would be, even if I wasn't medical, I should go back and sort of be part of the burial teams or something, because I have very specific, strain-specific Ebola antibodies that are very, very valuable. Yeah. So I don't think we'll ever get to the point where I walk into an isolation unit in my scrubs and no PPE, just because the implications of that for everyone else are no good. But we'll need to understand this a little more. We think probably at least we're getting maybe 10 years of strain-specific immunity. There probably is some crossover of that immunity to other strains, as you know, with Ebola, but some degree of immunity will be there. So I'm much happier to go back actually now, to be interested. So I'd love to.
Jane.
I just wanted to comment on this in terms of the evolution inside some of the treatment centers. We were talking about this weekend in a meeting, that in Elwa 3, which is the big Ebola treatment unit in Monrovia, there used to be a massive, but now there's a smaller cohort. But when patients are starting to recover but have not yet become seronegative, so they can't be released yet because they haven't, the Ebola virus isn't, they're still testing positive for it, but they're feeling better, they sort of naturally come to be caregivers, especially for the children. And what we noticed was that, particularly for the children in the ward, anyone that was feeling better would start to become a natural caregiver. And so we had to figure out how you deal with that. So you don't want to put either patient at risk, but the idea that a child could be held and bathed and comforted when they're crying is so great. And so they're starting to get to the point where the protocols are coming in place of what's the right protective gear for somebody that's supposedly immune protected. What kind of testing is necessary? Should they be tested for antibodies monthly or quarterly so that you're sure that they're still protected? And so those things are starting to take place, and we're starting to have caregivers that are choosing to work in the facility and to stay. They're asking to become employees so that they can continue to care for patients. And I think I think the act of solidarity is hugely compelling, and I think it will have a big difference. It'll make a huge impact on the patients. And so I think that that's one bright spot.
Yeah.
It's really great.
And in addition to the fact that they have the antibodies, you know, it's hard to explain unless you've sort of been behind the curtain there, and those patients have. They recognize that how much dignity is robbed by this thief of a virus. And to return with antibodies and provide the kind of, often care is quite simple that they need. They need their stool cleaned. They need to be picked up and put back in bed. Can be done not by an infectious disease specialist, yeah, easily. And to have people taking care of them who know about the need to lend them some dignity for a little while, because they're being devastated by a disease that is taking it all away from them. the way people die is a really horrible thing.
It reminds me of that famous quote that we were taught at medical school, in that the art of caring for the patient is caring for the patient.
Peabody.
Peabody.
Yeah.
Alex, a couple of audience members have asked about what has become known, I guess, as the crisis within the crisis. Yes, we have an Ebola crisis, but at the same time, as a result of it stressing the healthcare system, we are now seeing elevated rates of deaths from malaria, from typhoid, maternal deaths. And one audience member asked what steps can be taken, if any, to deal with this other crisis, this crisis within a crisis.
There's actually a third crisis, which is that the countries of Sierra Leone and Liberia in particular have their economies shut down. There's no economic activity. There's 5 million children who no longer go to school. There are food shortages that are looming because there's been no farming activity. Essentially, this is a virus that, although it has killed 5,000 to 6,000 people, and I put inverted commas only, because clearly there are many other diseases like HIV or malaria, has created a pandemic of fear and a pandemic of let's stop doing anything else because it's too dangerous to do it. That is really destroying these countries. But let me shift to what happens to all the other sick people or all the other healthy people who need vaccinations, who need to be delivered. And by the way, mothers who, well, women who are pregnant and are very vulnerable to the HIV virus, to the Ebola virus. A pregnant woman who gets Ebola has a 95% chance of dying, and her baby almost 100%. So Ebola is particularly vicious in pregnancy. And a pregnant woman who has Ebola who delivers has a high probability of infecting the people who deliver her, because delivering a woman can be messy and gets more messy if they're bleeding more than they usually are. So many women have been turned away from delivery units. In fact, delivery units have shut down. In Liberia, many of the midwives dress up as if they were treating Ebola patients in order to deliver women. And so inevitably, services, particularly for women and children, are suffering. And so we're having a lot more. I don't know if the data is out yet, because it's difficult to collect this data when you can't even collect the data for Ebola. But clearly, once this is over and we collect the data, we will see far more deaths in malaria, in TB, and of course in HIV. People with HIV are supposed to collect their medications every month. Many of them are not even coming to the facilities because A, there may be no one there in the facility, but B, they fear to be infected if they come to the facility because they say in that hospital there is Ebola. So what do you do? I think we are learning as we do. You have to create some safe space that could be away from the hospital. You may have to take services closer to the people, have mobile units that deliver essential services. It would be crucial to be able to do rapid diagnosis of Ebola, because then if patients are coming, you can quickly tell this is not Ebola and be able to treat them safely and do triage. But this luxury of being able to get a rapid Ebola test is not available in most places. We really need a point of care test where you can do like a diabetes glucose test, where you prick a finger, literally as the patient is coming in, decide they have Ebola, they don't have Ebola, and then take them to a safe zone.
And I believe some countries are exploring mass drug treatment for malaria, where you basically just give everybody malaria drugs, so that if someone turns up with a fever, it's less likely to be malaria.
Correct. Yeah. And so all of that we're really learning. This is unprecedented. We've never dealt with this before. But as usual, guess who's suffering most? It's the women and the children.
We've had some questions about social media, and I believe, Alex and Ian, that you spent some time today at Facebook. Do you think that social media has a role to play in these sorts of outbreak situations? And if so, what kind of role?
Ian, you want to?
I certainly think social media is going to be here and better for the rest of our time, and in a number of different fronts in this epidemic, I think it's very, very, very relevant. one of the things that we talked to Facebook about today was their push to increase connectivity, which, for example, when I'm on the ETU, I don't have any charting. I can't take charts out. They have to be decontaminated. And essentially, all you have to write down about a patient is a whiteboard that has a name. Do they need IV fluids that day? Which is typically, especially infectious disease, we don't like to do that, right? The ability to have connectivity at an ETU site and simple hardware that allows you to input patient information and quickly send it out without having to decontaminate things would be absolutely remarkable. The ability for, it's a lonely place behind the curtain, yeah? It's an absolutely lonely place. Now, it was lonely for me in Emory, which I was looking through a window at my brother and my family. I could talk to them on the phone. It was nothing compared to what it's like on a typical ETU in one of those 3 countries. Thinking about how to connect families in that setting, which I think plays a huge part in people's recovery, that sort of connection to people. And of course, the education that can happen very quickly. And finally, Alex brought up a really good point this morning. You know, one of the difficulties, especially in Sierra Leone, we're struggling with now is a number of different partners, many of them funded with equipment, but not really talking to each other well. So using at least the connectivity coming from social media advances would be an incredible way to connect a number of different players quickly.
Jane.
So just on the technology use, there's a start actually in Kailahun next week. They're bringing in a health record system that is tablet-based, and the key to it was developing a case that you could dunk in chlorine, right? Oh, right. Because the tablet has to travel. Sure. Like, it's really hard for a doctor to go through a ward or a nurse to go through a ward and remember 12 patients and then put the right thing in the right box at the end of the ward. It's troublesome. And so, you know, there's been some experimentation, but I think there's a long way to go. Like, why don't we put video recording in so we can do observations from outside of the tent? Why don't we have tents that have plastic walls so you can see in from the outside? Why don't we give everybody a camera? Why don't everyone who brings their phone in loses it because it has to be, you can't decontaminate a cell phone, so their only connection to the outside world is their personal cell phone, and we take it away from them when they leave, if they leave. So I think that there's a lot that basic technologies could really make the process more human, both for the caregiver and more importantly for the patients.
The other, this is not necessarily social media, but developing cheaper, more comfortable PPE is something that we've talked about today as well. So if you could develop one of these pumper fans, you know, that the Emory staff taking care of me were really, really comfortable. And that's very, very different from being either in an MSF suit or one of the Tyvek suits.
How long could you tolerate being in one of these suits?
So the suits are different. The MSF suits are impermeable, so provide you a little more protection. But you can't, I did this for the first few days. It's very difficult to stay more than an hour. In fact, you begin to risk not only dehydration, but heat stroke and things like that the longer you stay in those suits. For a long time, we used a semi-permeable suit called a Tyvek suit. And you know, if you push it, you could stay hours in the ward, but you're pushing it. And I used to come out and, you know, my boots would be full of sweat and you'd pour them out. So it's difficult to, already difficult if we had none of this, but very difficult to take care of patients in that setting. Much less the difficulty in connecting to a patient who can't see your face.
So we are not going to have time for everybody's questions, I'm afraid, although I invite all of you to have a glass of wine later and speak directly with the panelists. But in the last 4 or 5 minutes, I hope that we can perhaps cover 2. Many people have asked about the intersection of Ebola and culture, particularly cultural practices around burial. One audience member asks, if burial practices are one of the ways in which the virus is being transmitted, how do we work with that practice? What can we do? And I'd be interested in anybody's response to that.
So maybe let me kick off. Of course, you have to understand, all of us get very defensive when our cultures are questioned. when this question was put to some African, he said, but hold on, in the United States, the SEALs, when any of their members gets shot down or is killed in enemy territory, they always go back to fetch that body, even if they risk dying. That's the military burial culture. You don't leave a dead person, even though 3 or 4 other people may die. That's not very different from a village in Guinea or who say, my brother has died, and I understand that touching that body and bathing it may create risk for me, but if I don't do this, I have not done my obligation. I will not be respected. So we all do things that to other people may not make sense. However, if you get enough death, I assure you culture does change very quickly. And I think what you do need to adapt cultures, any culture, is good communication and trust between governments, between the population, but most importantly, between community leaders, religious leaders, traditional leaders. And perhaps this was not done as quickly enough in these 3 countries for various reasons. But that's now beginning to happen. And I think definitely one of the reasons why in Liberia there has been a fair amount of movement is that there has been a lot of change in the culture of handling dead people.
So we have time for just one more question, and I'm going to make it a rapid-fire round in which you each get a minute.
This is quite fun.
It's a very easy question, and that is if you could draw out one lesson from today's Ebola outbreak that can help us prepare for a future pandemic, whether it's another Ebola or influenza. What do you think that one lesson might be? Ian, and your time starts now.
Whew. So, you know, a lot of my lessons are personal. I think, given my short time, I'm not a sort of long-term expert on a lot of the global health themes here. I'm a clinician at the bedside. I think taking advantage of this opportunity to understand what we can about this particular infection now, Alex has talked about the window, is crucially important, not just in terms of a specific vaccine or a specific antiviral, but in understanding how we can nimbly and agilely respond as things pop up, which has been a very early upstream problem as this epidemic began. So I think understanding how, whether that's surveillance, whether that's building capacity, obviously in health systems, but in the people who are on the ground is a very, very important long-term 40,000-foot view issue.
Thank you. Jane?
You touched on my response, but I'm going to say the word is adaptation. So I think that if you just look at it from a systemic perspective, there's a lot of unknowns. There's unknowns about the evolution of the epidemic. There's unknowns in the data set. We don't have good information. And it takes a long time, it takes too long today to get the systems in place to do appropriate treatment, isolation, and all the full care package in terms of community education, burial teams, ambulance services. I think we have to develop some new methods, and I think that necessity is the mother of invention, and I think there's enough people on the ground that maybe these solutions will come out, and I think we need to focus on adaptation.
Thank you. And Alex, you have the final word.
So the simple answer is to say stronger health systems, but it's also an understanding that health, the entire population is responsible for its own health. So you have to build not just the traditional health systems, hospitals and clinics, but you also have to develop community systems that benefit health. And that includes early surveillance and detection of cases within the communities. It means the initial responders to illnesses within the community. And it includes linkages between the communities and the health system itself. But all of that chain that keeps people healthy through health promotion, prevention, and treatment needs to be urgently strengthened. And that's what I have been about in IDI in Uganda for the past 14 years. That's what Accordia Global Health Foundation is talking about. And this will not just benefit Ebola, but also benefit many other diseases that we know in Africa, but possibly other diseases that are just waiting for a chance to escape and come out into the world.
Thank you, Alex. That concludes our program for this evening. I would like to dedicate this evening's broadcast to all those who have lost their lives in this current outbreak, including the very many healthcare professionals. So on behalf of the World Affairs Council and Accordia Global Health Foundation, I ask you to join me in thanking Alex Coutinho, Jane Coyne, and Ian Crozier for this truly magnificent discussion, incredibly rich, incredibly insightful, and many thanks as well to you, the audience, for posing such wonderful questions. Good night.